Welcome back to everyone in our audience. We have a special panel that I think will be very exciting for everyone with a group of leaders from Nemours Children's Health. I'm going to have each leader introduce him or herself, and then one of the leaders, Alex Koster, is going to help me to moderate this panel with these wonderful leaders and parse a number of questions regarding social determinants work in a pediatric health system. So first of all, welcome panelists.
Hello.
Thank you.
Hello.
Great to see all of you. Why don't we do this? Let's go around. I'm going to do this clockwise according to my screen. We're all living in this Brady Bunch world now where we're all just boxes. So I'm going to, in this order, Crystin Liboma, Na-Tasha Williams, Lavisha, Pelaez, and Alex Koster. Why don't each of you just go ahead, say your name, title, and briefly your role at Nemours connected to the subject. Crystin, please go ahead.
Sure thing. So my name is Crystin Liboma. I'm a quality improvement specialist with the value-based services organization within Nemours. I've been with Nemours for just over 2 years. I work primarily around improving outcomes related to flu, related to various other vaccinations, and reducing ED utilization.
Wonderful. Thank you so much, Crystin. Na-Tasha, welcome.
Yes, thank you for having us. My name is Na-Tasha Williams, and I'm a population health specialist with Nemours. I'm currently co-leading implementation of social determinants of health screening in 20 of our primary care locations throughout Pennsylvania and Delaware. And that initiative launched in late December of 2020. And we are currently approaching 1 full year of implementation.
Wonderful. Welcome, Na-Tasha. Lavisha, welcome.
All right, thank you. So my name is Lavisha Pelaez, and I am the Health Equity Research Associate in the Office of Health Equity Inclusion at Nemours. I've been with Nemours as well for a little over 2 years. I'm going on 3. And my role is I'm involved in health disparities research and also in a variety of projects across the enterprise related to health disparities work or health equity. And then I also work with students who are our future when it comes to various professions within the healthcare industry.
Wonderful. Thank you so much, Lavisha. Alex.
Hello, I'm Alex Koster. I'm the Director of Analytics and Technology with the Nemours Value-Based Services Organization. And my role is basically to provide the analytics and technology infrastructure to support both our value-based care contracting journey and also our population health, social determinants, and equity programs. So I'm all about the data.
Great, thank you. And Alex, I know you wanted to make an introductory statement on behalf of the team.
Sure. So like many pediatric organizations, Nemours is kind of on a journey of transformation that is connected closely to the move to value and how it interconnects with population health. And our premise is that investing in children's health is the single most powerful means to ensure a healthy generation and a more robust economy. So we know we have to transform the way we think about health, the way we pay for it, and the way we leverage the power of economic power, social connections, et cetera, of our health systems in order to engage in this journey. We have this concept, we call it well beyond medicine. So it really, to me, speaks to the idea we have to look at the whole child, at root causes, at social barriers, at structural barriers, and other things that stand in the way of this healthiest generation that we're trying to bring about. So I'm pleased to be joined by my colleagues today who are heavily engaged in this type of work, whether it's on social determinants on health, whether it's in looking at disparities in health equity, or understanding how these different things impact an area that may seem cut and dry in the value-based world, like reducing ER utilization, but really it goes well beyond, again, the clinical and the medicine and into these other areas that impact our children.
Yeah, exactly. I think what all of you at Nemours are doing is fabulous, and it certainly is a very complex journey that you're on because there's so many elements. What are you all working on right now related to disparities, to equity, health equity, and to social determinants of health? And Alex, I know you'll help me.
Sure, why don't we start
which
with Crystin?
leader- Yeah.
Sure, I can start. I mentioned before, I'm working with a flu vaccination group. And so we've been trying to increase our vaccination rates over a number of years. But within the last year, we've realized that there is a discrepancy between the vaccination rates for our white patients and the vaccination rates for our Black patients. So we're really focused this flu season on increasing or reducing that gap, increasing vaccination rates specifically for our Black patients. So that's one area that we're looking at. Another is around ED utilization. We are trying to reduce the kids who come into the ED maybe for unnecessary or they could have gone maybe to a different place. And so as we're looking at that specifically for patients who are on Medicaid, we're realizing that there is, I think the majority of the patients are Black or African American. And so we have to work uniquely with that specific population to reduce their use and determine why exactly they're using that. And then finally, clinical pathways is another role that I've taken on, and just making sure that all of the work that we're doing is standardized across all populations.
Wonderful.
Na-Tasha?
Oh, you're muted, Na-Tasha?
As I
Sorry.
mentioned earlier, we are currently in the process of implementing social determinants of health screeners across our primary care sites in our Pennsylvania and Delaware regions. We've taken really the first year to do a few things, one of which is to really make sure that our staff are fully aware of why we're doing this type of work, really making sure that they have really good understanding of why the social determinants are really important and the relationship that they have to overall patient health, as well as working with our staff to implement the processes, but also continue to refine and streamline the processes as we move forward. And then we've also worked with our patient population to really make sure that they kind of understand why we're asking these questions and really making sure that they have a comfort level and a level of understanding as to the reasons why some of these personal questions are being asked of them when they come into the practices with their kids.
Terrific.
And last but not least?
Yeah, so with my role, I have the privilege of being able to work with many different individuals and departments. You know, Crystin and Tasha both been able to collaborate on different projects. And so a lot of the work that I do is sort of this, I'll say, like consulting sort of framework, in the sense that we have many individuals who are interested in addressing health disparities issues within their areas, whether it be orthopedics or the emergency department or primary care. And I get to work with them on special projects, on research, and really help them push the needle when it comes to trying to address these issues and have more of a health equity lens. Something else that recently I've been able to be involved with is working with a team of individuals on a health equity dashboard that, you know, I'm sure we're going to have more conversation around. This is something that has been modeled after, I believe it's Minnesota Children's, if I'm not mistaken, but modeled after work that they've been doing. And it's something that a lot of pediatric and even adult healthcare systems are, you know, starting to look at ways of really trying to monitor and address disparities within their system and track it and find a cohesive way to address it across the entire enterprise. So those are some of the things that I get to work on in this lens.
Alex, do you want to add anything to what has been said about this specific question?
Oh, I think each of these projects, as the more we dive into them, the more they're going to intersect.
Yeah.
And I think that that's something that every group is going to realize that nothing lives in a vacuum. If you're addressing social determinants, you can't address social determinants without really exploring the impact of systemic racism or what populations are being impacted in different ways in different geographies, although we're going to touch on that a bit with the ahas in a moment. The other thing is it's not just about the project and suddenly we're going to transform the experience of patients and families. It starts inside with the teams involved and the education we need in order to even be able to have the conversation. And so that's been, I think, a great journey to be on together and to learn from.
Wonderful. Now, one of the important things we all know is that we want to start with mission and vision, and then we need tools. And so let's talk about data and analytics. The majority of people viewing this session will be connected to health IT in some way, either directly or indirectly. So they will be very curious to know how each of you are interacting with data, analytics, and technology, including the EHR. And as you work with data and analytics, what issues or barriers are you running into? And what opportunities do you see going forward on analytics? So Alex, would you like to help me direct the question?
So I think here we can start with the Social Determinants Project, because that is probably the most EHR intensive build out of these. And then we'll move to Crystin's work on her different initiatives. And then Lavisha can speak to what we're finding with our equity dashboard and other work that she's involved in. So Na-Tasha?
Awesome. Yes. So now that we have almost a full year's worth of data that we've collected in the EHRs, we're really trying to use that data to identify some of the trends in determinants. We're really looking at breaking the results down by region, community, and sometimes even individual practice level, so that it really can help guide us as an organization to identify where to deploy appropriate resources. Really looking at where there's opportunities to build new relationships or build upon existing relationships to bring the necessary resources to bear to our patients and families so they can get the adequate supports that they need to help them with the issues that they're currently experiencing.
Terrific.
One of the things I think we also, we realize that we're using the technology to collect data and populate the EHR. But once that information is there, I think for us, the really good thing is that we have the ability to go the next step and to allow our providers and our care coordination staff to use that and have the ability to engage with our patients and families in conversation to kind of, really see what things are popping up in the surveys and then really work with them collectively to help resolve some of those issues.
Wonderful. Yeah, a lot of times we can't stop at numbers. We have to actually connect with people so they can enlighten us as to what the numbers mean. Lavisha, I know you have something to share too.
Oh, I think I may have seen Crystin light up. Did you want to?
Oh, I'm sorry. Did I go in the wrong order? I'm sorry.
No worries.
No worries.
Sorry, Crystin,
Yes.
please go ahead.
So we have access to a ton of data. And so one of the tricky parts is sort of distilling it into a specific story and make sure obviously that it's factually correct. One of the issues that we've seen sort of differences across, we have a hospital in Delaware and then one in Florida. Our Florida hospital, the data may not, especially like the racial data, may not necessarily be there, or if it is there, we aren't really sure if it's entirely correct. So we sort of cross-compare some different diseases such as sickle cell, just to understand whether or not, for instance, the racial data is directionally accurate. Some of the types of analyses that we're doing, again, we have this whole plethora, a whole ton of data, so we have to distill it down. But we're using Healthy Planet and Click to do some analyses. One of my favorites is control charts, and so we use that pretty frequently in my projects. And so control charts are just a way to statistically look at the data and determine whether or not if something is out of bounds or in bounds according to what you would statistically assume that it would be. And so we're tracking this data over time, especially as we get into implementation efforts, and just seeing whether or not our interventions are working, whether it's just due to chance, or whether it's not working and maybe we need to go back to the drawing board and change things. So those are just some of the examples of the ways that we're examining and looking at the data that exists.
Okay. Crystin, could I ask a follow-up? What are the biggest challenges in what you shared? Where is it hardest to address issues?
So it can be very difficult to, as I mentioned, there's so much data. Everyone has a ton of questions. It can be very hard to just actually step back from the data at times and really make sure we could spend a ton of time digging and looking at things this way, looking at things a different way, looking at things by zip code and seeing, who's coming from where, et cetera. And so you can kind of get stuck there. And so one of our challenges with this team is often taking a step back from data and just trying to do something with what we do have, while continuing, of course, to do some of those analyses on the back end. So I would say yes, the plethora of data, while helpful, can be challenging.
Yeah, that makes sense. Lavisha.
Yeah, so I mentioned earlier that one of the areas that I'm able to do in my role is consult with a lot of individuals on either patient-facing or even, internal associate equity disparities questions that individuals may have. And when it comes to data and analytics, I have a public health background, focusing in epidemiology and biostatistics, and so I'm able to bring a lot of that skill set into that work, and consulting with individuals on, they have all this EMR data. What can I do with it? How do I analyze it? To the points that were raised earlier, is it complete enough? Is it accurate for the type of research or work that individuals are actually trying to do?
Yeah.
And so those are some of the things that I help individuals kind of work through, and really, to Kristin's point, take a step back to look at what they have and see if it even is even going to answer the question that they may have, or is there something else, another data source that may better serve what they're trying to get at, whether that be even qualitative work and actually meeting with families and doing surveys and things like that. And so that's kind of like one part of the data analytical stuff. I also mentioned the equity dashboard as well. That definitely utilizes the electronic medical records data and pulling that information in. There are multiple amazing dashboards that have been created by teams that Alex, leads, that really help us look at the various trends when it comes to the areas that we're interested in. For this dashboard, to start off with, we are interested in flu. That is one of the metrics we're looking at. We're also looking at access and arrival rates as well, because, after multiple conversations, we realized that before we can really address some of the disparities that we're seeing, for instance, within a particular department or specialty care area, we need to take a step back again and actually look at, are people even making their appointments to begin with? Are, there transportation issues, or are there other things going on to where they're not even coming in the door, let alone, trying to address, whether or not they're having severe sickle cell episodes or other things like that. So, again, kind of taking that step back and really trying to be more upstream. And that's more of like the public health aspect of my background, of thinking more upstream when it comes to the data, and kind of working our way back down. And so I think with the work as well, just some of the barriers that I've noticed in the years that I've been doing this is that you have a lot of isolated efforts going on, individuals that are very interested in this work, but very siloed. And so I think for me, I've definitely served as a connector where I may have somebody from one department approaching me with the same idea that another department has already been working on, and I can make those connections. And so I think that's something that, over time, hopefully will, be lessened as far as that siloed work, having this dashboard and more concerted efforts across the enterprise. And also there's just a standardization of the analysis as well. So that way, regardless of what one person's doing in one department or another, it's the same sort of measurement, and we're able to compare apples to apples at the end of the day.
Very good. Alex, do you have any thoughts on what you've just heard?
Well, so one of the things that we've talked a lot about is how much do we advance on these projects with the known constraints on the quality of the data, right? Yeah. So when it comes to demographic capture, there's volumes written on this and focus groups all over the country and things like that. And we run into it too. So my view is we have to build the tools assuming the data are all correct, and then work to improve the quality of capture. So every associate understands, for example, don't assume based on people's appearance what race or ethnic background they come from. Or one of my favorite stories is I have a colleague who is from the Philippines who has the same last name as my mom. And if you read the last name Villanueva, you might make assumptions. And yet we're Puerto Rican and they're from the Philippines. And so how do we educate our staff to make sure they know, this is something you have to ask, and here's the right way to ask and the respectful way to ask. And over time, we'll see that improvement in the quality of the data. And there's other areas as well. The data from health information exchanges is amazing. It allows us to do so much in terms of patient management, but we can't control the fact that the one organization submits registration events to a health information exchange and another one only submits discharges and another one only submits admissions. It allows us to know a patient's been in the hospital. Is it something that I would draw up exactly that way if I wanted to do the ultimate research project? Probably not. Is it good enough to tell us utilization someone was in an ER? Yes. And maybe surrender that pursuit of perfection and data quality sometimes for the sake of being able to explore more broadly something like ED utilization.
Yeah, exactly. That makes a lot of sense, Alex. You're all deriving real insights here, and that leads to my next question. What kinds of aha moments have you had, moments of discovery and revelation? And what has the process of exploring these questions revealed that may not have been expected? So I know each of your teams is learning things. So share an aha or two. And to whom should I address the aha question first?
I'll start with Na-Tasha and then go to Crystin and Lavisha.
Okay, great.
So we've had lots of aha moments throughout this process, but I think one of the things that we've consistently heard feedback from staff reporting that families who seem to have it all together were in fact struggling. Some of our practices are in fairly affluent areas, and initially a lot of the staff expressed some reluctance in doing this kind of work because their assumption was that a lot of our families don't need this type of help. Our families don't need this. Our families are okay. And one of the things that they came to realize by doing the survey is that a lot of the families that they assumed were okay were actually, in fact, struggling. And so we were consistently hearing that. And I think some of our biggest champions for this project have come from some of those sites, because they realized that if these families who we think all have it together are struggling, we can only imagine what the struggles are for some of our other families in other communities. And so I think that was the biggest aha from this whole year's worth of process that I can speak to.
Wonderful. And who are we going to next?
Crystin?
Crystin, yeah.
So one of our biggest aha moments, for the flu work, we looked at the vaccination status of the children who were not vaccinated with the flu vaccine, and we found that they were actually getting vaccinated by every other thing. And so every time they had an appointment and it was time to be vaccinated, the child would get vaccinated, except when it came to flu. And so we learned that it wasn't just about, access or education, but that there were some underlying things happening. Additionally, we, went to some research and looked into some things, and we actually found that for children with Black mothers, and if the mother is more educated, that's actually a predictor that they will not get the flu vaccine. And so there's some unique intersectionality there. And so some sort of, again, that aha moment was there, that this wasn't just about education. This isn't about necessarily the education of the mother, but that there are some deeper things that are underlying here. So what we're doing is going to do some focus groups and some surveying just to understand a little bit more of the reason behind that. And so that's, super interesting thing that we've learned from the data. Additionally, with the ED utilization work, initially we looked at our own internal Nemours data to see what the reasons for ED visits were. When we expanded the data to see if a patient was visiting any hospital in the area, we found some other diagnoses that had not popped up for us inside of Nemours. For instance, pregnancy. We found that a lot of our teenage patients were going to, for instance, an adult hospital specifically for pregnancy. And so that allowed us to tailor some different approaches that we would not have known to look at otherwise.
That's really interesting. The deeper you've been digging into the data, the more complexity you're finding, right?
Yes, exactly.
And I wonder, just as a super quick follow-up, Crystin, with the resistance of moms to vaccinating their children for flu, am I understanding that was there a crosshatch between education and race or another demographic that was happening?
Yes. So specifically for Black mothers who are more educated. There was also some in the study that we looked at, there was also a predictor for, I think, patients with Mexican parents and whether or not they spoke English well or maybe less well, and I think they self-identified. So that was another example that we were able to see how much they were getting their children vaccinated.
I think that's just fascinating because it would be so easy to be conceptually lazy and just like stop at the first step. But then it's like, oh, wow, that's interesting. Like the more educated Black mothers are less willing to, and then you want to, and then you're like, well, why? Right? Like what was it? So that's wonderful. Thank you for that insight. And we haven't heard from Lavisha yet on this one.
Yeah, and if I can just add to the flu example, because that's something that I've also been involved with. One of the things coming into my role is really looking over time how the various interventions that Nemours has done regarding flu has impacted the population. And I think another aha moment that really led to the work that is currently being done with the equity dashboard and what Crystin has laid out is realizing that although we've seen our vaccination rates increase over time, that disparities gap has in many ways either stayed the same or actually widened in some cases. And so I think that really struck some people in realizing that although, yes, our vaccination rates overall may have gone up, these interventions may have worked for some people. The reality is that they don't work for everyone, and that really, if we're talking about addressing disparities, we have to start thinking outside the box and really start trying to understand why that gap is just, so persistent.
Oh,
Think we lost Lavisha, or
I think we lost her temporarily. So,
and
Lavisha,
you hear me?
you're not coming through. Now we can.
now we lost about
Okay.
the last 30 seconds. If you want to just go backwards about 30 seconds, we can.
It is breaking up again.
Maybe what we should do,
Okay. How about now? Is that better?
Okay, go ahead, try.
Okay. All right. Hopefully y'all can hear me okay. But yeah, no, I was just saying that, whether it's flu or well child visits or, insert whichever illness, disease area that you're looking at. I think one of the main aha moments for myself and the work that I do with multiple departments is really trying to get over those assumptions that one shoe fits all or one tactic will work for all, and that when you start diving into those deeper layers, that you really are going to need to start trying to understand those complexities and the intersectionality that exists and the motivations behind why patient families do or do not do certain things.
Yeah,
So.
absolutely. Good. Thank you so much. Alex, what ahas have you had?
Well, so Lavisha used the great word struck, and I am one of the people who was struck because I was very proud of this amazing effort and great technology, whiz-bang texting, language sensitive, push out reminders for flu thing we had built, and the results looking at a system level, and then we looked broken out by race, and I went, oh crap, excuse me. It left people behind, but yet at the same time I said, well, I'm so glad we're doing this, because otherwise we would not have, we would never have known, and that's part of how we make disparities worse, even with good intentions, and the term good intentions or positive intent and all of that, it's used so much in this work, and to actually see it happen with something that is as, I'm going to call it sterile as technology. I think it's humbling but valuable at the same time. The other thing is, what does it mean to address a question of equity and a question of outcomes and disparities that you can't solve by throwing money at it and just being blunt? It's not just about more resources, more access, more hours, more transportation, when you may have questions of trust, or you may have questions tied to history and other things. And I think part of why we agreed to push on the flu project is because we're going to have to tackle those questions, and they're not easy, and they're not necessarily comfortable, and there isn't a purchasable Band-Aid necessarily that you can immediately go to. And so those were huge ahas for me.
Oh, wonderful, wonderful. Well, I would love to ask you all, why don't you share with us any wisdom you might have on how you communicate the why to your colleagues? I think what you just said, Alex, is so interesting. You're all doing incredibly important work. For some people you'll be communicating with and interacting within the organization, it might put a bit of a burden on them, additional burden, or at least they might feel it does. How do you communicate to colleagues why we want to capture additional data, why we want to do some of this analytics so that we can improve access or improve equity or better capture social determinants? How do you communicate with others that you're interacting with professionally on the sense of mission around this? And who would like to begin?
Go ahead and start. So I think staff understanding the why is really crucial for them to be able to adequately do the work that needs to be done, deploying the tool, providing the resources and things of that nature. I think for staff in a medical setting, their goal is to keep people healthy. And so for us, it was really important that we continue to push the connection between addressing these non-medical social issues to patients' overall short-term and long-term health. Once we had an opportunity to really do that and show some of the connections, we actually got significantly more buy-in. And I think one of the things, if we could do it over again, we would do more of that education on the front end where we were trying to work through implementation and education at the same time. I think if we had to do it over again, I would prefer that we do the education first to make sure that staff had a really solid understanding. And then I think we would have gotten a lot more buy-in a lot quicker.
Who else would like to weigh in?
Yeah, I can go next. I think for me, again, kind of with my public health background, I think about how, we all know that the country is diversifying, and at Nemours we see more what we would say like traditionally minority population patient families than we do our non-Hispanic white families. And so when we are talking about trying to address disparities, have health equity, not thinking about, families that may not be, native English speakers, or our immigrant families, or our minority families. In my opinion, it's a missed opportunity, and really you're going to be left behind if you are not thinking about how majority of our patient families are probably going to be Spanish speaking at some point in the future, especially in our Florida hospital, for example. And so to not have adequate technology or data that captures that fact, it really is going to leave the organization at a disadvantage to adequately provide care and, create the healthiest, generation. And so, I think about that and just how we really need to be on the forefront of really embracing the fact that our patient families is a diverse group of people with a lot of different needs and complexities and intersectionality. And, we really need to embrace it and to be creative in the way in which we do the work that we do.
Wonderful. Crystin, did you have thoughts?
Yeah, so I think the flu example that we've talked about a few times is a great example of the why. So, we were doing all of this great work. We were texting patients, having these like automated texts that were saying, "Hey, come in for your flu shot," et cetera. And it was working on the surface of things. We started seeing our flu vaccination rates go up, and without that input, the demographic data as an input, we would not have been able to dig a little bit deeper and see that while it was working for our white patients, our Black patients remained untouched by this intervention. And so without that input, again, we would not have known that. We would not have known to try something different, to look at our patients holistically, and to try a different approach, a different angle. And so that's, a great example of the why for when our staff are inputting this information at the front end. One of my favorite examples, and this isn't at Nemours, it's at a former organization I belong to, but they looked at x-rays for patients who came in with broken bones. And so all patients are supposed to get a bone study if they come in with broken bones, just to rule out physical abuse by the parents. And so they found that actually the Black patients were getting the recommended bone studies every time, and the white patients actually were not. And so in this case, we were leaving behind our white patients. And so that's another great example of why it's so important that we're actually capturing this data, because you never know who's getting left behind unless you're doing the digging.
Yeah, wonderful, wonderful. Alex, any thoughts?
So I think the message needs to be tailored to the audience, and obviously I work a lot on our contract support and kind of lining up how are we going to be successful. So one of the things I've really kind of enjoyed is kind of telling the story that connects this work that's so critical to the health of children, also to things that make sense to finance or make sense when we're looking at payer reporting and things like that. They're not separate. One of the amazing things about moving more to value is you don't have to keep this world as something else we're doing if we have the money to spare. It's so critical to our success within new payment models and new incentive models. And then we see payers joining us in that journey and saying, what if we incent you to close disparities? And what if we incent you to identify, we incentivize you to identify social needs and report on them, so they can then move some of that awareness into their realm even further, and in a way that they can quantify, rather than saying, well, we know it to be true, well, here's actual numbers. And so I think tailoring the message, or having some messaging that makes sense to each kind of audience, really makes a big difference.
Wonderful. We just have a few minutes left. I would just like to ask each of you to, and we can go in any order, just share a last piece of wisdom or advice for our audience based on everything we've discussed. Anything that you would just like to share that you think is interesting and that people should know. Who would like to go first?
I'll go. Well, when you were asking that question, the first thing that came to mind is how, as I guess as my piece of wisdom would be to not be afraid to, what we say at Nemours, have courageous conversations, and to ask questions and to be vulnerable. I think with this work, everything from the way in which data is collected, and whether or not with racial data, whether, it should be categorized specific ways, or whether we should even be using, the categories that we have currently. Like, there's so many kind of, I'll say, conversations that can make people feel uncomfortable and not really know how to have the conversation, or the best way to approach the conversation with different individuals. Or they may have an interest in it, but just have really don't know where to start or who to ask, and are afraid to even take that step because this is something that's new for them, but they, want to start that journey. So I feel like, my piece of wisdom would be to just have those courageous conversations and to put yourself out there and be vulnerable. And I think that when I've found myself asking those questions, I've been personally surprised at the reactions of how open and I'll say gung-ho people are with actually putting, things into action. And I think about how if I would have never, said anything, or just thought it wasn't my place to say anything, how much further behind we would be in some of the work that we're currently involved in. So that would be my piece of wisdom, I guess.
Absolutely.
And to piggyback on what Lavisha stated, I think having those conversations are critical, but also moving forward with the work. There is no perfect way to do this. So we've had lots of starts and stops, but I think the moving forward and at least attempting to, as best as possible, get to a place that's close to perfection, even though we know perfection really doesn't exist, but to continue to strive to do what's in the best interest of patients and families. We know this, collecting this information and being able to help and resource families is super important, particularly now in the environment that we're in. And really just to continue to push forward. And even though there's going to be moments of uncomfortability and discomfort, to kind of push past those, to get to the other side, to where, you're comfortable with doing the work, you're comfortable with asking the questions, you're comfortable with the resourcing, but also where the families are comfortable in providing that information and that those struggles that they're facing back to us. So that's kind of where I would leave it.
Thank you. That's very wise. Crystin, any last thought you'd like to share with us?
Yeah, so two thoughts. I'd say first is to always be careful to check assumptions. They're very, very easy to have. Even for me, I had my own assumptions about, especially with that education and the flu example. So making sure that you're checking those and actually doing the digging. And then the second is, it's very easy to get caught up in the numbers and to get caught up in, your Excel and your charts and everything. But sometimes or most of the time, it makes a lot of sense just to get in front of the patient, ask the family some questions, and really hear it from them directly versus staying stuck in your spreadsheets.
Yeah, absolutely. It does. Get out there and talk to people, right? Yeah. And Alex, any last thought?
I think I wanted to say what Lavisha said, and then I wanted to say what Na-Tasha said, and then what Crystin said, and because it's all so true. I think in my role, a lot of the things you hear that you go, yeah, but then you live, like, if you're not getting to a point of being uncomfortable, you're perpetuating something that needs to change. That is real. It's been humbling real in many ways, and but also understand that you'll learn something. And so for me, it's listen more, and understand that there is a lot of expertise in this, and just kind of trust that the process will reveal where the investment needs to be, where the work needs to be, and where the projects need to be. And I think I'm really encouraged by what we're finding, even though, to Na-Tasha's point, nothing is perfect. It doesn't have to be. That's not what it, where success will happen. Success will happen if we consider things differently and implement new processes and new considerations. It's not about, should that count as 2 ER visits or 1, which is sometimes where we get stuck in the data. And we have to stop treating that or using that as a safe place to hold all of our conversations.
Yeah, I think that's absolutely right. I just wanted to say that I think that all of you are doing amazingly, enormously important work, and that you should be encouraged to move forward. I know you are being encouraged. This is the hard, complex, time-consuming work that is moving our health system forward. In order for us to enhance equity, to care for all of our populations, all of our people, and to really leverage data, especially social determinants data, to figure out what's going on in communities so that we can better serve patients and families. We have to do the work that you're all doing. So I want to congratulate you on that. I want to wish you all the best going forward, because this is very inspiring, actually. And I think that the culture at Nemours is such that you have a wonderful foundation of support. And I know it goes all the way up to Dr. Moss and the very senior leadership who are letting you walk the talk when it comes to all of this. So thank you, all of you, Lavisha, Na-Tasha, Crystin, and Alex. Again, I want to wish you all the very best. And I so appreciate, on behalf of our audience, both our audience who are about to view this and those in the future. I want to thank, I always love greeting our people in the future. It makes me feel very Star Trek. But anyway, thank you all very much. You've been fabulous. And this concludes this session for today. Thank you to all of you in our audience for participating by viewing. Thank you very much.
Thank you.